Before starting the presentation of renal disorders, let me review briefly the basic aspect of the kidney structure and function. This picture illustrates the position of the kidneys and especially the good perfusion. The kidneys receive approximately 25% of the cardiac output through the renal artery. This slide illustrates the functional unit of kidneys, the nephron, and especially let me stress on the importance of the mesangial space near the glomerulus. The mesangial space, it includes two types of cells, distinct cell types, intrinsic glomerular cells and also tissue macrophages, mesangial cells. These cells both contribute to the immune-mediated glomerular disease by their production to and also response to cytokines, especially growth factors. The filtrating membrane includes three distinct layers: the endothelial layer, the basal membrane, and an epithelial layer, podocytes. There are two types of nephrons in the kidney: cortical nephrons and juxtamedullary nephrons. The loop of Henle of juxtamedullary nephrons is long, thus contributing to the concentration of the urine. The kidney excretory function, the production of urine, results from three main processes: the glomerular filtration, tubular secretion, and tubular reabsorption. Let me remind that the effective filtration pressure depends not only on the hydrostatic pressure of the blood into the glomerular capillaries, but also on the oncotic pressure and the intercapsular pressure acting in the opposite direction. A substance, after being filtered into the glomeruli, cannot be subjected either to additional secretion or to reabsorption. As an example, inulin. That's why the inulin is used to measure the glomerular filtration. Another example, a substance may be filtered and later completely reabsorbed. An example, glucose. The glucose is reabsorbed in the proximal tubule. Or, after filtration, no absorption but secretion, thus to be cleared fully from the plasma, from the urine. So, an example, paraminohippuric acid, it may be used to determine the blood flow through the kidney. The kidney function is related also to the regulation of the normal blood pressure. For example, if increased the blood pressure, this will cause increase of the pressure into the afferent arterioles and as a consequence increased glomerular capillary hydrostatic pressure, increased glomerular filtration and increased excretion of salt and water, thus to cause finally a reduction in plasma volume and especially the extracellular fluid volume and to decrease the blood pressure, to normalize the blood pressure. In addition, the increased afferent arterial pressure will suppress the production of renin by the kidneys and to decrease the formation of renal of the angiotensin II. Later, let me know the angiotensin II suppression will cause decrease of the blood pressure. Angiotensin is a potent vasoconstrictor, thus increasing peripheral resistance in the vascular system. Various types of transport are presented into the nephron: simply diffusion or selective transport by using uniports, symports, or antiports, specific ion channels, and active transport, against concentration gradient. This is realized using energy. Energy expenditure is necessary. This slide illustrates the active transport of sodium against the concentration gradient accompanied by energy expenditure. The energy necessary for active transport is supplied by oxidative phosphorylation, thus the mitochondria are abundant in the tubular cells, as illustrated on this picture. This slide illustrates the quantitative changes of different substances along the nephron. After being filtered, this is here the percentage shown. For example, inulin, as already noted, is not secreted or reabsorbed, so all inulin will be excreted into the end urine. Creatinine is not also absorbed, but it is a small portion of insulin is excreted additionally into the lumen, so creatinine is also excreted in an amount approximately equivalent to the inulin. So that's why the creatinine and inulin are used to define the glomerular filtration. Other substances are reabsorbed progressively along the nephron. The glucose is absorbed in the proximal tubule, and the sodium and water and other osmotically active substances are absorbed along the nephron, so finally 0.5 to 1% are excreted into the end urine. The concentration of the urine is crucially depending on the function of the collecting tubules. The cells in the collecting tubules express vasopressin, antidiuretic hormone receptors, thus increasing the permeability of the epithelial layer, mobilizing the aquaporins and allowing the water to be reabsorbed because of the huge osmotic gradient. The interstitium expresses high osmotic concentration. The alteration in kidney structure and function depend on the site of the lesion. They present, for example, as glomerulopathy or as tubulointerstitial disease. They are also depending on the nature of pathogenic factors, infectious factors, toxic factors, immune factors, metabolic factors, hemodynamic factors. The clinical presentation also differ because of the two main types of presentation: nephrotic, with a profound proteinuria, but no clear evidence for inflammatory reaction into the glomeruli, and nephritic, with variable degrees of proteinuria associated with red and white blood cell in the urine. I will now list the kidney functions subjected to abnormal changes. Not only the excretory function, glomerular filtration, reabsorption on excretion is affected, but also, as already noted, blood pressure may be affected. Calcium metabolism may be affected because of the production of vitamin D3 in the tubule, thus influencing the calcium absorption. Also, erythropoiesis may be affected because of the production of erythropoietin in the juxtaglomerular apparatus. Kidney injuries are due to three main groups of causes. First, pre-renal, for example, hypovolemia, volume depletion, heart failure with decreased cardiac output, use of some medicine impairing the autoregulation of the kidney, such as non-steroid anti-inflammatory drugs, and less commonly, liver failure. Liver failure produces a hepatorenal syndrome. Intrarenal intrinsic mechanism may affect the vessels, vascular damage, as observed in vasculitis and also in long-term hypertension, especially in malignant hypertension presenting very high blood pressure. Glomerular damage, mainly due to acute inflammatory process, acute glomerulonephritis, and interstitial, as observed in pyelonephritis, acute or chronic. All they may cause ischemia, infection, and also to produce additionally nephrotoxins. Postrenal mechanisms include mainly obstructions, for example due to stone production, prostatic disease, eventually malignancy, tumor presence. The urine composition is important in diagnostics of the urinary disorders and kidney disorders in general. The urinary syndrome may present with qualitative changes such as proteinuria, hematuria, pyuria, glucosuria, cylindruria, leukocyturia, bacteriuria, and amino aciduria. Normally, a very small amount of low molecular weight proteins is filtered and usually it is immediately reabsorbed in the tubule, so the final urine does not contain proteins, or if they are present, a very low quantity, for example 0.3 gram per 24 hours. We have to collect the urine along the nictemeron and to analyze after the collection the whole amount. Damage to the glomeruli will produce presence of proteins into the end urine, proteinuria. It may be light, up to 0.5 grams per 24 hours, or moderate, up to 3.5 grams per 24 hours. It is marked or pronounced if exceeding 3.5 grams per 24 hours, and massive as observed in nephrotic syndrome, massive exceeding 15 grams per 24 hours. Most commonly, the proteinuria presents as selective proteinuria, increased amount of low molecular weight plasma proteins, albumins, but also a non-selective proteinuria. Presence of both albumins and globulins into the urine may be present. Cylindruria. This is the presence of renal cylinders, also known as casts, in the urine. The presence of casts indicates an organic lesion of the nephron. Different types of casts may be present: protein casts or cylinders, granulated, erythrocytic, pigment. Hematuria. This is a condition in which the urine contains blood or at least red blood cells. Here, gross hematuria seen in the urine or microhematuria observable under microscopic examination. The criterion is the count of the erythrocyte to exceed 3 cells per field. It may be due to a renal disorder, for example glomerular damage, or also extrarenal generated into the ureters or into the bladder, for example calculi tumor inflammation of the urinary ways. Leukocyturia and pyuria are characterized by presence of leukocytes and or pus into the urine when voided. Glucosuria is observed if the plasma level exceeds the filtration threshold of the transport capacity. The amino aciduria, when present, indicates a decreased transport capacity of the kidneys, especially defective transport systems in the tubules. The diuresis changes may present either as polyuria. The amount of urine per 24 hours exceeds 2 liters, or oliguria. The amount of urine per 24 hours is less than 0.5 liters. Usually, they indicate glomerular changes, but not only. The urine excreted may demonstrate low specific gravity. This is an evidence for the inability to concentrate. Or sometimes the kidney cannot form urine with a higher or a lower specific gravity than that of the protein-free plasma. This is known as isostenuria. This slide presents the change in the glomerular function, in the kidney function in general, due to damage to the glomeruli and production of glomerulonephritis. They are known as nephritic syndrome. In nephritic syndrome, hematuria and even red cell casts are present in the urine, decreased glomerular filtration rate, and oliguria, proteinuria, azotemia, edema, and hypertension because of retention of substances normally being excreted, especially sodium and water, and hypervolemia production. In nephritic syndrome, there is an immune complex deposition either with a subendothelial location or in the glomerular basement membrane or mesangium. Thus, destruction of glomerular architecture is due in part to the local cytokine production. This slide illustrates the deposition of immune complexes in the glomerule. Let me note that the deposition or a formation of an immune complex activates immediately the complement system. Thus, MAC, membrane attack complex, and activation of C5 recruiting the polymorphonuclear cells will produce injury and mediate glomerular infiltration with inflammatory cells and later inflammatory injury because of the release of reactive oxygen species, proteases, leukotrienes, and others. Mesangial cell contraction will contribute also to the reduction of the glomerular filtration rate, while the damage to the podocyte especially will contribute to proteinuria. This slide shows on the left a normal capillary, glomerular capillary, and on the right a glomerular capillary affected by immune complex deposition. The immune complex deposition may be subendothelial on the membrane or subepithelial below the podocyte layer. Important to note, the subendothelial as well the mesangial localization will immediately activate inflammatory process by recruitment of inflammatory cells and by activating the mesangial cells. In opposite, the deposition subepithelially here in the podocyte will not produce inflammatory changes simply because the inflammatory cells cannot cross the membrane. This deposition subepithelial will cause another syndrome, the nephrotic syndrome. To summarize, the immune complex deposition will activate the complement, forming membrane attack complex, thus exerting cytotoxic effect on all cells and also releasing C5a, the factor recruiting neutrophils, and triggering an inflammatory reaction with release of inflammatory mediators. The proteinuria observed is usually selective hypoalbuminemia. The hypoalbuminemia will cause reduction of the plasma oncotic pressure and, as a consequence, edema. The nephrotic syndrome, as already mentioned, is due to immune complex deposition at or under the epithelial cells, the podocytes, very often accompanied by morphologic changes in food processes of the podocytes. This disorder is characterized by a marked proteinuria, as already mentioned, albuminuria exceeding 3.5 grams per 24 hours. It is accompanied, of course, by hypoalbuminemia and edema due to the decrease of the plasma oncotic pressure, and also hyperlipidemia and lipiduria. The changes in acute glomerulonephritis involve mesangial, epithelial, and endothelial cells. However, the glomerulonephritis may progress to turn into a chronic process involving fibroblasts causing progressive fibrosis and accelerating the apoptosis. Clinically, the acute glomerulonephritis demonstrates an abrupt onset of hematuria and proteinuria and decrease of glomerular filtration rate. It is caused most commonly by infectious disease, for example, post-streptococcal or bacterial, pneumococcal, viral, as a consequence of mononucleosis or hepatitis B, or parasitic in malaria and toxoplasmosis. Multisystem disease such as lupus erythematosus also may cause glomerulonephritis, and some primary glomerular disease, for example the Berger's disease, known as immunoglobulin A nephropathy. Also miscellaneous causes such as serum sickness or irradiation may cause acute glomerulonephritis. In accordance with the clinical characteristics, glomerulonephritis may be rapidly progressive. Recovery does not occur and will cause renal failure. The rapid progression may be due to the effect of some drugs, such as hydralazine or penicillamine. It may be due also to immunosuppression or development of hypertension, excessive hypertension. The most common mechanism for the deposition of immune complexes, this is an immune attack in which there is a cross-reactivity between an antigen of the infected organism and antigens of the infective microorganism. For example, group A, beta-hemolytic streptococcus. Similarity between the streptococcal antigen and the host antigen is responsible for the deposition of immune complexes into the glomeruli, either subendothelially, subepithelially, or on the membrane or in the mesangium. In chronic glomerulonephritis, a cellular proliferation is present, either in the mesangium or in capillaries, and also obliteration of the glomeruli. Sclerosing chronic glomerulonephritis may cause obliteration of the glomeruli. Another subtype, this is the membranous glomerulonephritis. Tubulointerstitial disorders are caused mainly by urinary tract infections. The microorganism involved, Escherichia coli. Other gram-negative microorganisms are Proteus mirabilis, Klebsiella, Enterobacter, and Pseudomonas. Gram-positive microorganisms are Staphylococcus aureus and Streptococci group B, or at rare occasions fungal, especially in diabetics, Candida is involved. The penetration of the infectious agents may be achieved through the blood system. In bacteremia, this is common for immunocompromised persons and neonates. More commonly, the penetration is achieved through the urethra, the urinary tract. The obstruction and reflux in the urinary way are an important factor in generating the infective process. The urine retention acts as a medium for microbial growth, and the increased pressure will produce a reflux to the upper portions of the urinary system. Obstructions may be produced by stones, prostatic hyperplasia, even pregnancy in women. Catheterization, especially long-term catheterization of the urinary system, also may contribute to the infection. The clinical manifestations will depend on whether the infection involves the lower, the bladder, or upper, the kidney urinary tract, or whether the infection is acute or chronic. The pyelonephritis represents an inflammation of the kidney parenchyma. It is a tubulointerstitial disorder and also the renal pelvis. It is most commonly caused by Enterobacter, but also by Escherichia coli, Proteus, and Klebsiella. The infection usually ascends from the lower urinary tract, inflammation of the bladder, cystitis. Among the contributing factors, let me note again the pregnancy and the catheterization. Presence of diabetes is an additional severe complicating factor. The acute pyelonephritis manifests an abrupt onset with chills, fever, headache, back pain, tenderness over the costovertebral angle, general malaise, and symptoms of bladder irritation such as dysuria, frequency, urgency, pyuria, and hematuria, sometimes causing necrotizing papillitis. The chronic pyelonephritis is a progressive process. Scarring and deformation of the renal calyces and pelvis are observed. Because of the damage of the distal section of the nephron, the collecting duct, polyuria with isostenuria are observed, nocturia, proteinuria with the progress of the disorder, and finally renal failure. Nephrolithiasis is characterized by formation of stones. They may present as calcium stones, for example, in idiopathic calciuria, or uric acid stones in gout, increased purine intake, meat consumption. Cystine stones are observed in cystinuria due to defective amino acid transport in the tubules. Stuvil stones are composite stones. They contain magnesium, ammonium, and phosphate salts. They are usually indicated for urinary tract infection with Proteus vulgaris. The stone formation results from alteration of the solubility of various substances in urine, thus causing nucleation, precipitation of salts, and especially the dehydration favors the stone formation. This slide shows the supersaturation, the nucleation aggregation, finally renal stone formation because of the supersaturation, and especially at some occasions low inhibitors level may contribute. Any damage to the tubular cells disturbing the polarity as shown here will strongly contribute to the nucleation and formation of stones. This slide illustrates the most common stone, calcium phosphate stones formation into the proximal portion of the nephron, especially in the Henle's loop. Clinically, nephrolithiasis usually demonstrates by pain, flank pain. It is due to the obstruction of urinary ways and distension either of the ureter, the renal pelvis, or renal capsula. The severity of pain relates to the degree of the distension produced. Anuria may also be present due to bilateral ureteral obstruction because of stone presence. Hematuria is also observed due to damage by stones of the urinary ways. Let me note that hematuria may occur in the absence of pain. Passage of the stone in most cases usually requires only fluids, analgesia, and bed rest. The complications, especially due to formation of big stones, may include complete obstruction of an ureter with a backup of urine and increased pressure into the kidney, thus causing hydronephrosis followed by a permanent renal damage. Infection or abscess is rapidly destroying the involved kidney due to the obstruction and the hydronephrosis. An infection is due to the rapid growing of the bacteria after the obstruction. Because of the increased renin production in the obstructed kidney, hypertension may be another complication. Repeated kidney stones obstructions will cause progressive severe renal damage. The renal failure may present as acute or as chronic renal failure. The acute renal failure presents as a rapid deterioration of renal function resulting in accumulation in the blood of nitrogenous wastes that would normally be excreted in the urine. So, increased blood urea nitrogen and serum creatinine, together with a decreased glomerular filtration rate and oliguria, are the main signs. Also, hypertension and edema are observed. Most common pre-renal causes for acute renal failure is the extensive use of non-steroid anti-inflammatory drugs or angiotensin-converting enzyme inhibitors. Also, the renal hypertension due to artery stenosis may also cause acute renal failure. Intrarenal causes involve inflammatory disease, glomerulonephritis, and acute tubular necrosis, ischemia, poison effects, and hemolysis. The postrenal causes most commonly involve urinary tract obstruction, renal stones. Sepsis also may cause acute renal failure, combining prerenal factors, hypoperfusion, and intrarenal factors, cytokine dysregulation. Regardless of the origin, all forms of acute renal failure result in acute tubular necrosis. This slide illustrates the mechanism of the acute renal failure caused by ischemia. Tubular cell injury. The severe ischemia will cause irreversible injury, necrosis, apoptosis accelerated with obstruction, bycast, increased intratubular pressure, and tubular backleak, thus decreasing the tubular flow. This is the mechanism of the reduction of the glomerular filtration rate and oliguria. Even the reversible tubular cell injury may cause increased distal sodium delivery and increased tubular glomerular feedback, thus to reduce glomerular filtration rate and oliguria. Also, the ischemia will cause endothelial dysfunction in the glomeruli and to produce vasoconstriction and to complicate this condition because of the increased production of endothelin potentiating the vasoconstriction and the decreased production of the nitric oxide, the vascular relaxing factor. These are the effects of ischemia on endothelium. Also, the prostacyclin production, the vasodilating prostaglandin, is decreased. Let me note that the renal medulla demonstrates particular high susceptibility to oxygen deficiency, so the renal medullary hypoxia will immediately produce all changes already considered, especially the arterial vasoconstriction with consequence changes in the cell's cytoskeletal rearrangement, loss of polarity, sloughing of renal tubular cells, inappropriate adhesion, further tubular damage, and acute renal failure, sometimes irreversible. It depends on the duration of the hypoxia. In summary, two main mechanisms are involved into the pathogenesis of the acute renal failure. A tubular mechanism, the occlusion with cellular debris, and the increased intratubular pressure causes decreased glomerular filtration rate. And the other one, the vascular, the decreased glomerular filtration rate because of afferent arterial vasoconstriction and efferent arterial vasodilation. The changes are illustrated here. Increased vasoconstriction and decreased vasodilation. Also, damage to endothelial and vascular smooth muscle cells. The clinical manifestations include some initial symptoms such as fatigue and malaise, and later even dyspnea and changes into the auscultatory findings, for example, prominent third heart sound and peripheral edema. Oliguria is the major sign, and laboratory findings give evidence for azotemia and retention of nitrogen products, urea and creatinine. The increased ratio of blood urea nitrogen to serum creatinine is among the earliest manifestations of the acute renal failure. The chronic renal failure represents most commonly a complication of diabetes mellitus. It may be also caused commonly by hypertensive disease or glomerulonephritis, acute and especially progressing to chronic glomerulonephritis. Other causes include polycystic kidney disease and obstructions and infections of the urinary ways. The pathogenesis of the chronic renal failure is different from that of the acute renal disease. It represents the consequence of a progressive and irreversible loss of nephrons. Let me note the significant functional reserve of the kidneys. For example, even a loss of 50% of nephron will not cause an impairment of the renal excretory function. Thus, it is possible to donate a kidney to transplantation. The remaining kidney will compensate the loss of the other kidney. However, every systemic overload of the remaining kidney will cause progressive changes as follows. The compensatory hyperfiltration that may occur after the loss of 50 to 70% of the nephrons will cause progressive changes into the glomeruli, sclerosis and scarring. Thus, the increased rate of nephron destruction and loss will finally cause renal failure. This slide illustrates the outcome of the renal failure in a patient with diabetes, with an initial compensatory hyperfiltration and further damage of glomeruli, a decline into the renal function, and finally severe renal failure. This slide illustrates the consequences from the loss of nephron mass. First, the loss of nephrons will cause decrease of the biosynthetic capacity of the kidneys, thus decreased production of vitamin D3 will be observed with decrease of its level and decreased gut absorption of calcium. Hypocalcemia will be produced that compensatorily will stimulate the parathormone secretion. The parathormone secretion will cause extraction of calcium from bones and to produce the so-called osteitis fibrosa, and also remodeling and redistribution of the bone, osteosclerosis. The resulting decrease in renal excretory function will cause, first, retention of some metabolites acting as toxic at these levels. For example, the responsiveness of bone to the vitamin D3 will be decreased, thus potentiating osteomalacia causation, or protein caloric malnutrition and impaired bone growth, especially in children. This is the renal rickets. The decrease in renal excretory function unavoidably causes metabolic acidosis with additionally bone decalcification and osteoporosis. Hyperphosphatemia will be produced because of the retention of phosphates, with consequences potentiation of the hypocalcemia and potentiating the metastatic calcification. Clinical manifestations of the chronic renal failure include oliguria. This is due to the decreased glomerular filtration rate, and azotemia, increased level in the blood of the blood urea nitrogen and creatinine. The duration of this increase for 3 or more months is a sign of chronic renal failure. Osteodystrophy observed, as already mentioned, is due to disorders in calcium metabolism, as reviewed a little bit earlier, and also the sodium retention and water retention will contribute for the increased intravascular volume, hypervolemia, increased arterial pressure, and edema. The end stage of the progressive loss of nephrons is a state known as uremia. Excessive levels of nitrogen wastes into the blood and severe oliguria. It is due to a progressive decrease of glomerular filtration rate, fluid and electrolyte disorders, metabolic acidosis, and causes in addition hypothermia and accelerated atherosclerosis. The produced disorder and sodium balance and volume status, the sodium and water excess, may cause congestive heart failure and, as I already mentioned, long-term hypertension with significant edema and even ascites. The potassium balance is also disordered. Hyperkalemia is observed, which is extreme in diabetes mellitus with hyporeninemic hypoaldosteronism. The metabolic acidosis is a common characteristic of the chronic renal failure, especially of the uremia. It is decreasing the capacity to excrete acid and to generate buffers. This is the mechanism of the metabolic acidosis. Pulmonary abnormalities also may result because of the congestive heart failure. Pulmonary edema may be observed. Accelerated atherosclerosis in uremia is due to a decreased activity of the lipoprotein lipase. The mechanism of this phenomenon is not yet elucidated. Hematologic abnormalities are also observed in uremia, especially anemia. decreased production of red blood cells, which is the consequence of the decreased erythropoietin production due to the loss of the glomeruli of nephrons and juxtaglomerular apparatuses in the kidneys. The progressive loss of nephrons unavoidably causes decreased erythropoietin production and anemia. In severe uremia, urea is released through the skin and the mucosa, thus causing additional abnormalities such as pericarditis, peptic ulcer disease, uremic gastroenteritis, and with consequences anorexia, nausea, and vomiting. The release of urea from the skin will cause the so-called uremic frost. In addition, pallor because of the anemia will be present in the skin. Finally, endocrine disorders and metabolic abnormalities may be present, such as amenorrhea due to low estrogen levels and oligospermia in men, impotence due to low testosterone. The treatment of patients demonstrating progressing chronic renal failure includes hemodialysis. This is the apparatus known as artificial kidney. It is replacing the damaged kidneys, but it is just temporary. So this patient have to attend regularly, each week, once or twice, the hemodialysis unit and to be subjected to this procedure. The effective treatment of the chronic renal failure includes renal transplantation.